Hello, welcome everybody, and welcome to the this Bernardo's sponsored Changing the Face or Changing the Future for Children, Young People and Their Families, what the role of the new ICBs, ICSs, and the role of the voluntary community and social enterprise sector is in supporting that. We're grateful to Bernardo's for esteemed panel in terms of the speakers that we've got this afternoon, to look really at how the ICS can improve outcomes and reduce health inequalities across the health system, how we can share models of innovation and excellence around the care for children, young people, and importantly for their families as well, and inspire us to work differently. And I think one of the real thoughts behind the seminar is that during COVID, but this was a trend before COVID as well, but during COVID, health inequalities have really come to the fore. And I think what we've seen during COVID is health inequalities widening rather than narrowing. And I think that's been a trend that's been there for some significant time anyway. Perhaps it was too much to ask that a global pandemic would narrow health inequalities. It probably just operated in the same way as the previous factors have been in terms of widening them. So I think it's partly the pandemic that's driven more health inequalities, but it is very obvious that the widest fall or the biggest widening of health inequalities has been in children and young people and the support of their families. So the aim of this afternoon really is to explore what we can all do to support and address and help that, and how we as people who are interested in young people and their development, and organisations that are interested in their development, can really use this time, especially with the instigation of ICBs, to change the landscape in terms of how we're going to work with children and young people, how we're going to work across the system, both health, social care, voluntary sector, social enterprise, but right the way across the system, to really change how we deal with young people and how we affect their futures and how we can positively affect their futures. Just a couple of bits of housekeeping before we start. The slides that some of the panel are using slides, some are not. The slides will be available to you afterwards, and I think I'm right in saying, Ruxana, that the recording will also be available afterwards for people to share as well with others who may not have been able to meet or to come to the seminar today. There'll also be an evaluation at the end, so as you go through the session, please think about giving feedback and what feedback you might want to give at the end, and there'll be an opportunity to do that. I'll remind you of that at the end. So just a short introduction from me really to introduce the aims of the session. I'll introduce each of the speakers, but the detailed biographies are on the website and through the details that you've had already. So if we're going to talk about health inequalities, there's no one better to have with us than Sir Michael Marmot, who when I was speaking to my medical director about this, said he was the guru on health inequalities. I think undisputed guru on health inequalities, Professor of Epidemiology at UCL and Director of the UCL Health Institute of Health Inequality. So, Michael, very happy to hand over to you at this point for you to present to us.
Thank you. Big experiment. I'm not going to use slides, but the data are in my head, so I will use data. Every one of my reports, we begin with equity from the start. Give every child the best start in life. And that means two aspects: avoiding the negative and encouraging the positive. The negative, that you know well, adverse childhood experiences that damage children for life, through the life course. The positive, nurturing, cuddling, playing, reading to children, all the good stuff. which benefits children through the life course. And both the negative and the positive follow the social gradient. The greater the deprivation, the greater the frequency of 9 types of adverse childhood experiences. The greater the deprivation, the less the frequency of positive inputs from parents. That means that dealing with child poverty is really very important. So let me start with the bad news. There have been 3 recent challenges to health inequalities affecting the whole of the population, but today we're concerned with children. The 3 are the global financial crisis and the policies of austerity that were put in place in many countries, but particularly the UK, following the global financial crisis. The second is the COVID pandemic. And the third is the cost of living crisis. Government, central government, has a role to play in all of these. So let's take first government policy in the wake of the global financial crisis. From 2010, child poverty went up. In 2010, if you define child poverty as living in a household at less than 60% median income, child poverty was 18% in England. Before housing costs, after housing costs, it was 27%. And over the decade from 2010, that 27% went up to 30%. Wow. And if we compare other countries, UNICEF report card 16 ranks 41 countries. I told you I've got slides, they're just in my head. Rank 41 countries. The measure of child poverty is less than 60% median income, but it's calculated slightly differently, so the figures don't quite correspond to my 30%. But the average for these 41 rich countries is 20%. The best ranks 1 to 4 are Denmark, Finland, Czech Republic, South Korea, with poverty levels are around 10 or 11%. At the other end of the scale, you've got Romania and Turkey with poverty levels over 30%, 32, 33% by this measure. I said the average is 20%. We in the UK rank 31 out of 41. And the United States, pre-tax child poverty is higher in Finland than in the United States. Post-fiscal tax and benefits, child poverty in Finland is 11%. In the US, it's 30%. So government policy in those countries that have low child poverty levels, government policy is responsible for low child poverty. So we have a government that's been quite happy to have high levels and rising levels of child poverty. And you can see how it works. The tax and benefit system, the changes post-2010, meant that for families with children, in the worst off decile, 10% of household income, their income would have gone down by 20% as a result of changes the Chancellor made to the tax and benefit system. If they were in the second poorest decile, would have gone down by about 12%. So the poorer you were, the bigger the drop in income. Government policy was to make poor people poorer. And it worked. Child poverty went up. Wow. Now, if you look at the level of early child development for children age 5, readiness for school, the end of reception level, what you see, predictably, the greater the level of deprivation, the greater the level of deprivation, the greater the proportion of children with a poor level of early child development. Less deprivation, better early child development. So one obvious way to improve prospects for children is reduce child poverty. But a second finding is that children eligible for free school meals have a lower level of good child development than the average. But the gap between the poor kids and the average varies enormously across the country. In Hackney and Tower Hamlets in East London, the gap is tiny. The poor kids, children eligible for free school meals, have as high a proportion with a good level of development as the national average for all children. And the gap between all children and the poor kids in East London is really tiny, about 4%. Whereas in Bath and North East Somerset, the gap's 30%. The poor kids are doing really poorly. Wow, what's going on here? So in deprived communities, the poor kids, wait for this, in deprived communities, the poor kids are doing better than the poor kids do in more affluent communities. They still do worse than the average, but the deficit is much smaller in deprived communities. Hey, that's really interesting. You introduce this by asking what can ICSs do? And the voluntary community and faith-based sectors, what can others do? Maybe what they can do is reduce that gap between the poor kids and the average, because it varies enormously geographically. And in poorer parts of the country, the gap seems to be smaller. We've been working in Greater Manchester. I take no credit for this. They did it before we started working with them. But in Greater Manchester, the poor kids, the kids eligible for free school meals, were doing worse on early child development than free school meals kids nationally. They were doing worse than the average, but they were doing worse than the poor kids nationally. And in 3 years, Manchester closed that gap between the poor kids in Manchester and the poor kids nationally. So you can really make a difference. And that relates, so I've got good and bad news here. Let me go back to the international comparison for the bad news. If you look at what countries spend per child aged 0 to 5, the average for OECD, rich countries, is about $6,000 per child. In Norway, they spend more than $12,000. In the UK, we spend about $4,000. So not the worst. The US is worse than us. They spend $3,000. But not terrific. We keep hearing our politicians say, world beating this, world beating that. We're limping along worse than average. Not the very worst. The US always looks worse than we do, but not very good. What kind of ambition for the country is that? And I'm sure you, like I, have been really pleased that all the candidates to lead the Tory party have been saying, we've got to invest in improving conditions for early childhood. Our number one priority is using public money to reduce child poverty and spend on improving early child development. They've all been saying that, along with their priority to meet net zero by 2050. Isn't that encouraging? I've written a diatribe in the Lancet, which will come out not this Friday, but next Friday. Lower tax or greater health equity. these are alternatives. I hope you noticed I was being ironic. Nobody's who wants to be the next Prime Minister is talking about investing in early childhood. But that means that those of us who are concerned with early childhood have to be working at local level. How can we reproduce that Hackney and Tower Hamlets effect? Is it an ethnic effect? Bangladeshi families tell me in that part of London, we did it. We look after our kids. We reduce the link between deprivation and poor outcomes for our children. Is it a services effect? We spend more money per child in London than we do in the rest of the country. Is it a safety in numbers? If you're the only poor kid in Bath, North East Somerset, it's going to be much worse for you than if there are more kids around like you. But the whole principle of the work that we've been doing in places, in Greater Manchester, in Cheshire and Merseyside, in Lancashire and Cumbria, in Gateshead, in Luton, in Waltham Forest, the East London Foundation Trust. Gwent wants to be the first Marmot region in Wales. Coventry was the first Marmot city in England. The whole thrust behind our place-based work is there is a great deal that can be done locally. As I said, it does not let national government off the hook. But how can we break that link between deprivation and poor child outcomes? How can we break the link between more children going into poverty and poor outcomes? We know that the actions or lack thereof of the Chancellor with removing £1,040 a year with the taking away of the boost to universal credit and the cost of living crisis will, it's estimated, put another 500,000 children into poverty. So the challenge for acting locally is really huge. That just means that we have to be even more motivated, even more driven, working even harder to break that link between childhood poverty and better child outcomes. It matters for children's well-being, and it matters for their health and well-being right through the life course. There's no bigger issue worth tackling. Thank you.
Thank you so much for that, and impressive to have that range of statistics at your fingertips or tip of your tongue to speak through. But I think it's really powerful in terms of setting the scene for this afternoon and the scale of the challenge, and the scale of the challenge that sometimes is different from what is being driven from national policy and what we can do locally. And I think some of the examples that we've got through this afternoon look at what we can actually do locally, as well as what we can do to affect national policy as well. Thank you, Sir Michael, for starting us off in that way. I should also point out, I should have pointed out at the beginning, that there'll be two opportunities to ask questions as we go through this afternoon. So please, having heard that first session, please put questions in the chat, and then we can, I'll bring them together for the two Q&A sessions as we go through this afternoon. Our next speaker is James Sanderson, Director of Personalised Care at NHS England and Improvement. Has been involved in many issues about social prescribing for quite some time, and was previously a Chief Executive of the Independent Living Fund. Again, he will be with us for a while this afternoon, but you'll need to get your questions in slightly quicker for James, because he has to leave us part the way through the afternoon. So post them as he's going through his conversation. But James, you're very welcome, and great to hear from you on this topic. The floor is yours.
Thank you very much, Elliot, and a very good afternoon to everybody. I'm absolutely delighted to be with you all this afternoon, to get the opportunity to talk about the work that we're doing. And in many ways, it follows on hopefully quite seamlessly from Sir Michael's wonderful overview of the challenge that we face in health systems and in society in relation to how we support children and young people. So I'm going to talk a little bit about personalised care and the work that we've done in the NHS. When I talk about personalised care, I'm referring to giving people of all ages choice and control over the way their care is planned and delivered, based on what matters to them, not just focusing on what's wrong with them. And as Sir Michael has outlined, we know that the social issues that people face, we know that the postcode that people are born into, we know that the amount of money that they have, we know that the parents that they have are determinants of their health and well-being. And as a consequence, we need to, in health systems, focus more on the circumstances in which people are living. And actually, over the past 75 years, the NHS has done an amazing job of supporting people in really challenging situations. But actually, our response tends to be focused on biomedicine. And medicine is brilliant. We love drugs. We love the opportunity that medicine brings. And we know that modern medicine has given us the ability as human beings to live longer lives. It was less than 100 years ago that we discovered penicillin, for example. Some of these massive advancements in medicine have only been around for a fair few years, considering how long we've all been around as human beings. So whilst biomedicine is helpful, a very prime example of that is the vaccinations that we've seen for COVID-19. We know that there are limitations of how biomedicine can impact on society. We know that we have issues in society with addiction to painkillers, to opiates. We know we have issues of antimicrobial resistance. So consequently, we need to look at other ways alongside biomedicine. And a prime example that brings this to people's minds, I think, is looking at respiratory illness. So consider a child living with chronic asthma. They're prescribed Ventolin medication, they're prescribed steroids in order to support them. Or is the solution changing their housing circumstances? And that's where personalised care comes in, because this is about finding out what circumstances people are living in. It's about asking those questions. And I think actually, one of the most powerful tools that we have in the NHS is not an MRI scanner or some whizzy bit of technology. It's conversation. Sitting down, talking to people, finding out about who they are, developing a really clear plan for them about their whole life, and starting then to plan services around that need, I think is the way in which we need to focus. And we've been doing this through the delivery of what we call a comprehensive model for personalised care. Now, beyond those questions, beyond the plans, what personalised care does is give people the opportunity of support in different new and innovative ways. And I think this is really the answer to some of the challenges that Sir Michael has outlined. So how can we use personal health budgets, for example? How can we use the ability of people having cash payments to enable them to purchase care and support in a way that's more meaningful for them? So looking at perhaps a young person who's a wheelchair user, giving them a personal wheelchair budget, enabling them to purchase a wheelchair in a colour that they like, enabling them to purchase adaptations to that wheelchair, simple things that are going to enhance their life. I can remember an example of somebody using their personal wheelchair budget to use an adaptation to have a PlayStation controller, the ability to have that connected to the arm of the wheelchair. Now, that may seem like a frivolous thing for a lot of people. Why is the NHS making that adaptation? But actually, for that young person, the ability to get online with their friends, the ability to get together with their peers after school, and be connected as part of their community was incredibly important for their health and well-being. So looking at this in different ways, using money that we would spend in the NHS for certain things is one of the things that we need to do. And certainly using personal health budgets in a way that supports younger people to live more independent lives has also been incredibly important. So again, for people that are having personal and domestic care inside their own homes. I was talking a couple of years ago to a university student who'd just gone away to university at the age of 18, and he wanted to employ carers that were his age. He wanted to be out on a Friday and Saturday evening with his peers, with carers that he'd employed himself, that he'd had the choice. He said to me, no disrespect to middle-aged people, but I don't want to be out on a Friday or Saturday night with somebody that looks like my mum or dad. And you can understand, where that comes from for him in terms of his choice and control. Alongside this, we also have social prescribing, which is really creating a revolution in health and wellbeing. And alongside my NHS England role, I also have the privilege of being Chief Executive of the National Academy for Social Prescribing. Social prescribing now is a mainstream plank of NHS strategy. We've been employing link workers in every primary care setting across the country. And those link workers have the time to support children and young people as well as adults, looking at their individual needs and connecting them to community groups that may be able to help them. Maybe it's about issues of inactivity, maybe it's social isolation and loneliness, maybe it's concerns about newly being diagnosed with a particular condition or disease and people wanting peer support, meeting up with people that have been living with that condition for many years. Those sorts of things we're able to facilitate. And link workers connecting people to various activities in the community. And there's a myriad of activities available for younger people in sports and exercise, in the natural environment, linking to nature reserves, linking to all sorts of programs going on. The Wildlife Trusts provide bush skills. We've got Sport England providing a multitude of activities across the country in leisure clubs, and within the arts as well, the joining of community choirs, the ability to connect with peers through that. And we've seen some fantastic examples of social prescribing combining with personal health budgets as well. A programme in Nottingham where young people were enabled personal health budgets for their mental health and well-being, were able to set up a cycling club and support others with being part of that community and getting out and about on their bikes. So personalised care is about trying to think differently about the way in which we support people. Biomedicine is still incredibly important. It's a massive aspect of the way in which we keep ourselves well. But for children and young people, for the challenges that Sir Michael outlined that are societal issues, we need to find a different way. And I think starting with where people are at, asking them what matters to them, planning around their whole life, giving them the opportunity of choice and control through personal budgets, improving their skills, knowledge and confidence to live their lives, connecting them with peers, and making them part of the community through social prescribing is a really, really innovative and revolutionary way that can really support people and make the changes that we need. Thank you.
Brilliant. Thank you. Thank you, James, and thank you for taking us through the alternatives to biomedicine, which I think will become more and more important as we go through looking at this afternoon, looking at children. So I'm going to now move us on swiftly to Link Social Prescribing, which is a Barnardo's project up in Cumbria. That's an example of best practice with Barnardo's working with 3 primary care networks up there.
So we'd like to welcome you to our Children and Young People Social Prescribing presentation. My name's Ellen Buckley. I'm a Children's Service Manager for Barnardo's in Cumbria.
My name's Richard Massey. I'm a GP at Colbeck Surgery and I'm Clinical Director for Chiswick and Solway Primary Care Network. So we're here today to talk to you about our Children and Young People's Social Prescribing Service, which we started to develop in 2019. And as a primary care network, we worked with our neighbours in a neighbouring PCN to think about how we might develop social prescribing for children and young people. And we worked with Barnardo's right from the start. We wanted to look at alternative pathways to the traditional referral and discharge. We know that young people often find that very difficult. And Barnardo's were on board right from the start. We knew that Barnardo's had a great track record, particularly where we are here in North Cumbria. And so they brought with them that experience around governance, but also how to use the models of working that they'd used elsewhere and to make that fit for social prescribing. So we We're a very rural area in North Cumbria. We're Keswick and Solway, 40,000 patients across 7 GP surgeries. And we worked with our neighbours in Eden, who have an even larger rural patch, to develop this service with Barnardo's. Particularly, we felt was important right from the start was that Barnardo's offer to not only host the service that we funded through our primary care network funding, but also to develop a network of volunteers, which have been really key and integral to the development of the service.
So I'll just go through some of the pathways that we have. So early doors, we looked at what was needed in the areas. So we started a coordination path. So when GPs refer, they may be needing different support from different services, and we can offer that to get the right kid to the right place at the right time. We offer a community-based support, whereby we're in their communities, their neighbourhoods, where children feel safe and well, and provide that in libraries or in youth centres, so people can have a drop-in and some social element. We provide a school-based support, a 6-weekly offer based on whatever needs are coming through for those children at that point, and also our one-to-one work with the link worker, then we would move on to a volunteer as well. So who do we support? We support a wide range of children, young people. This was identified early by the GP surgeries that we wanted a junior and a senior and a post-16 offer, which we cover across our area. We take referrals from schools as well as GPs and other health professionals. We have young people on the SEND pathway because we know they can get stuck sometimes in the system, and that provides a smooth pathway for support as well as for their families. We've noticed a lot of young people identifying as LGBTQ+ or questioning the sexuality, which we work very closely with, and we have a young people's co-production group called Curious Youth, and we offer low-level emotional health and wellbeing, but we're part of the wider clinical pathway for children and young people right through to get the CAM support and crisis. We work very much at low-level emotional health and wellbeing in a social model. So in the beginning, the PCNs approached Barnardo's, as Richard said, to look at how we could support this need in an area and identify what the gaps were for children and young people. There was not much on offer, and a lot of GPs were identifying the need was there, but they didn't necessarily have the right skill set and support and pathways to get young people the need and the support at the right time. Just pass you to Richard.
So we answered initial meetings with Barnardo's and got to the point where we wanted to develop the service. The real magic happened when we went to the secondary schools and engaged with a group of children and young people. We went together as a steering group and met on a number of occasions with school council group, and we just went to them and said, this is what social prescribing is, this is what it looks like for grown-ups, for adults, and how would you design a service like this for children look like? Where would you want to meet with people? How would you want them to contact you? What kind of support would you want? And that was fantastic. It helped us shape the service and design how it would work. And that co-production has continued. And that initial group of children and young people actually helped us to interview first. What I'm really interested in as the clinical director is making sure that our link workers love their job. So we're really keen on making sure the workload is manageable. Barnardo's have been fantastic at making sure that the ongoing professional development of the team means that they've got all the tools they need, as well as all the clinical supervision that they need, the supervision that they need to feel supported in the roles that they're doing.
So what we needed to do was make sure we had a simple referral pathway and process, so GPs and other professionals clearly identified what needed to come this way and what needed to go elsewhere, and we have a clear governance and accountability which shows impact and evaluation alongside key KPIs, and that's with our health professionals, public health, our local authority, our borough councils, our schools, just so we're all on the same page regarding the need and the offer. Why our model works? So we believe that we offer a bespoke service for children and young people. It's about their strengths and working with their strengths and providing a sustained change. That's why we offer the volunteers afterwards. So if there's any dips in what's going on for them, they've still got that support there. We've currently got 11 volunteers working in the service. We work very closely with our partners and third sector providers to make sure the social offer is available in our communities. We're clear about the referral and what we take and what we don't take and why. We use a range of evidence-based practices there that you can see, which we're happy to share further. We offer a multidisciplinary team, so we have youth workers, social workers, teachers, which brings a new strength. And as we've said throughout, co-production is our golden thread.
So what's really valuable for us as a primary care network is to be able to kind of see the benefits of this, much of the work that's going on outside of the field of vision of a GP working day to day. So Bernardo's have developed this fantastic infographic which allows us to see the key data around the performance of the service, but also helps to share snapshots of positive outcomes and anonymised case studies. And we found this incredibly useful.
It just gives you year one evaluation of our success and impact by our independent evaluator, which I think shows itself how difference it's made to children, young people and families. We use a range of outcomes and we have some graphs that we're showing the journey that young people go on, and these will be available to you at the end by the host. We'll share these to give you more detail, and we're happy to share these further on our emails. This shows the level of the journeys that young people are on based on what the need was and where they are at the end. We have been successful in a number of awards, which we're very proud about. We won the National Social Prescribing Service for Children and Young People, which was because of our impact, and we were finalists in the Link Worker in May. And finally, last week, we were down at the awards ceremony in London with our MP, who nominated us for a Primary Care and Community Care Award, which we won for the regional, which we're very happy about. So the future, over to Richard.
So the future looks bright for the service here in Keswick and Solway. We, working with Ellen, and colleagues, Bernardo's team have managed to secure a significant investment to expand the service over the next 3 years. So we'll essentially double the number of lead workers that we've got, and hopefully expand to neighbouring primary care networks as well. Our funding has also allowed us to secure ongoing national level evaluation and a separate piece of work on codification, which will allow Bernardo's to look at how key elements of the service could be expanded nationally. So to summarise, from my perspective as a GP and as a clinical director for VCN, I'm incredibly proud to be part of this service, to be associated with it, and to be able to call Ellen and colleagues at Bernardo's my colleagues and part of our neighbourhood team. And this is something that brings joy to my heart every day, and we're very lucky to be part of it.
Thank you.
Good. Apologies for the difficulties on that. We've got a couple of minutes for questions, but probably no more than that have come through. I just wanted to Sir Michael first, just to say we've had a question that asked, were you saying that policy was going to lead to higher or to lower childhood outcomes and maternal mortality? And I think absolutely, I think I was hearing that you were. So we also wanted to ask the question that said, what are Hackney doing that Bath aren't, essentially? So what are the top 2 or 3 things that Hackney could do that Bath currently aren't doing?
So the honest answer is I don't know. It's a big issue of why Hackney is doing well and Bath isn't. And I don't know the answer. I speculated that there might be an ethnic effect. There is evidence that for kids in deprived areas, the Bangladeshi kids do better than the white kids. And so there may be an ethnic effect, family effect, nurturing children. That could be part of it. Well, you can't change the ethnic composition of Bath, but you can try to understand what it is that families are giving children. that may be breaking the link between them. The second is what the teachers tell us. In East London, the teachers tell us, we tell ourselves every day that poverty is not destiny, that we can make a difference. And the Sure Start Children's Centres that closed by the score during the decade from 2010, that preschool can make a difference, and good input from teachers can make a difference. And the evidence for that is pretty good. So I started by saying I'm not sure exactly what the reason is. I'm now in this speculation arena. Input from children, from teachers and other services, spending more, having more qualified staff can make a difference. Family can make a difference. And that's all very.
Thank you for that, and I think it's probably leads on to answer the question to James to some extent about social prescribing. So if we accept your premise that the alternatives to biomedicine, particularly for children and in this area, should be alternatives to biomedicine. To what extent can we move resources from biomedicine to social prescribing, and are we essentially relying on the voluntary sector as a country to prop up social prescribing, and we really transfer resources away from the biomedicine side of things?
Perfect. I'm really sorry about that. I was off mute, but on mute. Can you hear me now, Elliot? You can.
We can hear you.
Great. So yeah, I mean, finances and funding for social prescribing obviously is a big talking point. I think, firstly, it's a huge investment in social prescribing by government. I mean, we're the first health economy in the world to invest such a significant amount of money in valuing that psychosocial support alongside biomedicine. So £450 million into the recruitment of a whole army of link workers across primary care, and over 2,000 link workers now in place. And that's going to grow. That number's going to grow over the next 2 years as well. So there is a significant investment going into this. In relation to, who should fund the support on the really significant needs in society, I don't think it is, I don't know, I'm speaking from a health service perspective, but I don't think it is the health service's sole responsibility to provide the funding for social prescribing, because in many ways, what we're recognising through social prescribing, certainly in the NHS model, is that people do not need a biomedical intervention. They do not need support from the health service. So, I think that this is a case of bringing all parts of society together to support a solution that will start to change some of those real stark statistics that Sir Michael outlined for us. It's got to be every part of society. The health service can't achieve that shift on its own. The other thing that we're doing, obviously, at the National Academy of Social Prescribing, though, is looking at innovative ways of bringing organisations together, and at a community level through our Thriving Communities programme. We've brought organisations together across the arts, culture, sport, exercise, information, natural environment sectors, and we brought funding in from both national and local governments, along with philanthropic and private sector investment. And I think when you bring those partnerships together, you can do truly transformative things. And I think that's the way we need to work in the future.
Thank you so much, James. I understand you have to leave us now, but so Michael will be with us for the rest of the session, so we'll be able to pick up some of the Q&A at the end of the session as well. But thank you, James, for joining us this afternoon. So the next section was me. So I'm Elliot Howard-Jones. I'm chairing this afternoon session, but when I'm not doing that, I'm the Chief Executive of Hertfordshire Community NHS Trust, and also one of the provider representatives on the new Hertfordshire West Essex ICB Integrated Care Board, and the lead SRO for children within Hertfordshire West Essex as well. So I was going to give you a very health perspective, I think, and an unashamedly health perspective of the children issues and how we can feed that into the ITB. So very briefly, so why it's important and why it's so difficult within health, and I think some simple steps that we can take to try and raise this up the agenda a little bit more. So I always say about children's development is children's years are almost like dog years. If you don't get the development right and you don't get the support right, then you fall so far behind that actually it almost becomes impossible to get out of that hole. And I think we've got across Children and Young People Services, we have some really extraordinary and horrific waiting times from previous commissioning decisions. That means you could wait quite a long time for services, which means that your peers have moved away from you. By the time you get that intervention, it's an intervention that was should have got to you 12 months ago, and it's really, really difficult to catch up. And that not maximising that intervention when we can do it has lifelong implications, as Sir Michael has already said, about the way in which a good childhood can set you up for life or prevent you from achieving your goals in life. So I don't think the NHS understands this. I don't think it really understands the real way in which it's holding children back. And I think all of the people on this call are obviously advocates for children in this area, and I think we have to think about how we advocate and how we get that agenda widely heard. So why is it so difficult? Why is it so difficult to get that across? Because lots of us have children, some of us don't, some of us do, but they're not infrequent within society. So why is it so difficult to get that message across? I think because we have three NHS areas that we look at. So the whole children and young people offer is deeply fragmented. We have a universal offer that's health visiting and school nursing that goes out to, as it says, all children. We also have an education and development arm that looks at particularly speech and language therapy, occupational therapy, physiotherapy within the developmental journey. And we have emotional wellbeing and mental health, which is to some extent overlaps with the education and development, but to a large extent runs slightly separately. We also have local authority areas, so local authorities are immune from having silos within their delivery as well. Education, social care, public health, housing don't always sit in the same place within local authorities, and so there is to coordinate between them. So we've got a large number of silos, but actually the children, their minds and their needs don't fit well to the silos that we've designed in the system for them. Actually what they need is integrated, holistic intervention. Look at the whole child, and this is where the difference between Bath and Hackney might come in terms of how those services are linked together is as important as the amount of money that is put into each of those individual services. So what to do? I think it's really important within the newly formed ICS, ICBs, to have a real champion around children's services. It's often said that children's services are item 8 on any agenda, and they should be item 1 or 2, and certainly talked about in a much closer to the top of the agenda. It's a very, as James has pointed out already, it's a very healthcare focused system, focused on biomedical inputs, and particularly focused on waiting times in A&E and waiting times for elective surgery, neither of which are particularly applicable to children in most cases. So I think we need to, in each ICS, in each ICB, have a champion. You're all enthusiasts for promoting children's services. You need to find them and you need to nurture that person who's that senior leader. We need to measure what's important. At the moment, we don't measure children's waiting times in the same way that we do adult waiting time. Why do we not talk on the national news about the number of children waiting for developmental input in the same way that we talk about adult waiting lists and people waiting for hip operations and for knee operations. And to some extent, if we don't as an NHS measure the things that are important to us, we'll continue to undervalue them. It needs to get onto the agenda it sounds boring, and it is to some extent. Plumbing is really important, I think, in terms of is our children and young people services being talked about in strategy and performance meetings? Are they on the decision-making discussions that go on between organisations? Are they in all the joint working groups that are now flourishing and being set up under integrated care boards? Are children central to that focus? And that's where you need a senior leader, I think, within each ICB who is really promoting that, who really unashamedly gets into every meeting and says, why have we got halfway through this meeting and only just now starting to talk about children? Why is that the case? Why do we, and how do we change it, and how do we make sure that we're measuring things that are important? So I think it is a fragmented system. It is fragmented in health, but it's also fragmented within social care. We do quite a lot of work with voluntary sector who can bring something to that and bring real benefits in terms of their understanding of particular cohorts of patients. But again, it adds another level of complexity to manage within that. So there needs a real focus, it needs a real airing at those ICB meetings, and I think the resetting of the ICBs is an opportunity to get children right at the top of the agenda where they need to be. So that's what I was going to say, and why I was interested in chairing this afternoon's session as well, because I'm trying to do that within Hertfordshire, West Essex, and I think that's starting to bear some fruit because other people are starting to raise children before I do in meetings, which I think is always a good sign. Because we're on quite a tight time scale. Roxana Darby, who's the first ever Director of Health for Bernardo's, I believe, is going to speak to us about the work that the Bernardo's do. She's been in the NHS and charity sector as a commissioner, board member for a long time. I won't say for how long, but it was, she has been for a long time and has a huge amount of experience. So I'll hand Roxana to you to take us through the next item on the agenda.
Thank you very much, Elliot. I'm just going to bring my slides up. So, can everybody see that?
Yes, everyone can see that. Great.
Brilliant, thank you. So Bernardo's is really proud to have a 156-year history of being brave, being agile, and continually learning and transforming the services we deliver to tackle inequalities for children and young people. In terms of what we do, we deliver a really diverse range of services, and last year we reached over 380,000 children. Within the services that we run, within 1,000 services that we run, we have 62 child and family health centres which work at the heart of communities, and in our Healthy Child 0 to 19 services, we go to where families are and within their context. That's why we don't really describe families, young people and children as hard to reach. As a charity also, we have huge untapped resources of things like our 630 retail shops that are located on high streets that are accessible to local communities. And I think as we face increasing challenges of providing healthcare in the right places for children and young people by people that they trust, the VCSE sector can really offer the NHS a huge partnership opportunity of thinking outside the box to solve some of the wicked problems that the NHS is facing. The crisis facing children's health and well-being and inequalities that they are experiencing has reached a very critical point. And I started first back in 1989. My first job was in a children's development centre in Bradford. And I believe that if we don't collectively accept responsibility for the urgency of the situation, the inequalities that we're seeing now are going to become entrenched, and they're going to become the norm in the future. And as Sir Michael mentioned, there is unequivocal evidence now that if we don't set the conditions for children's neurological, physical and emotional development from early childhood, they will have worse health outcomes, educational outcomes and life outcomes as adults. As Elliot has mentioned, the child and family health system is really fragmented at the moment, and it's facing some of the most significant challenges in its history. NHS figures show that we've got more than 100,000 more children waiting to be seen by specialists than a year ago, and 12,000 of those children are in limbo waiting for more than 1 year to start their treatment. And while the 82 million the government has promised to create a network of family hubs in England is really welcome, we know that spending by local authorities on early intervention has decreased by 48% since 2010, and we've had the closure of over 1,000 children's centres. And the NHS workforce crisis is definitely set to deepen, and we know that, health visitors and school nurses, the percentage of those that are in post have decreased significantly since 2010. So we're really at a juncture where we have to adopt very different workforce solutions and strategies going forward, and take some risks if we're really going to meet some of these challenges. Because both the human and economic cost of getting it wrong is huge. So Michael, identified some of the statistics, but babies in the most deprived neighbourhoods in the UK are consistently twice as likely to die as in the least deprived. And for some groups of children, like Black, Asian and minority ethnic children, they experience higher rates of asthma, obesity rates, and of the 1 in 6 children that now have a diagnosable mental health issue, the level of need is much greater in minoritised communities. So with ICSs, there's a real opportunity to create a future system where we can have longer term commissioning cycles, more holistic wraparound models that we've heard about in terms of social prescribing, and models that are increasingly more family centred in their approach. And what we're seeing at the moment is families presenting at health services like A&E departments for underlying support and social needs that can't be solved by clinical interventions or medical prescriptions. And we recently run a pilot in 2 paediatric accident and emergency departments in Birmingham Children's Hospital and in Lister Hospital in Stevenage. And family support workers worked with the A&E teams, and our family support workers are trained in things like running parenting classes, infant feeding programs, etc. And when I visited them a couple of weeks ago, I asked them about the sorts of things that they had seen over the last 6 months. And they told me that one of the cases was a mother that had been unable to breastfeed her child for over 3 days, that they supported in a very calm environment to start breastfeeding again. And with this particular woman, it was her 3rd child, so it wasn't even, her first baby. And the other sorts of support that they were providing were actually going into people's homes where families were presenting at A&E multiple times over the last 6 months for respiratory conditions. And when our family support workers went into their homes, they found damp housing and were able to liaise with their local authority and the council around trying to find a way forward. But this pilot was funded by Winter Pressures money. It only ran for 6 months, and we know that the NHS will continually face a winter crisis, and some people say almost an annual crisis in A&E departments right across the year. And so we have to really think, when we know that 80% of what affects health, physical and mental, is from outside of the health system, how we can really start thinking very differently about the sorts of solutions that we put in place on a permanent basis. In terms of children's mental health, it is an area that all ICSs are grappling with, and I think for ICSs it's really important that they learn from good practice both locally and nationally as well. And this is an example of our solar service, which is based in Solihull in the West Midlands, and it is a CAMS integrated service that's a partnership between Birmingham and Solihull Mental Health Foundation Trust, Barnardo's and Autism West Midlands, and it provides high quality emotional wellbeing and mental health services to children aged 0 to 19. We've been running it since 2015, and the focus of Solar, which was named by young people and co-produced by young people, is on timely access to appropriate support, as opposed to the service being based around tiers or thresholds that people need to meet. And anybody can refer into it. Parents can refer into it, schools, the criminal justice system, local authorities. Children only tell their story once, and there are information sharing systems that are integrated across all agencies. And I think most of all, there is a real respect and integrity between professionals, recognising the value and skills that each professional group brings to this particular service. And the outcomes speak for themselves around this particular service. So it's constantly highlighted in the NHS National Benchmarking Reports. It has a below average waiting time from referral to assessment of 5 weeks. So what I wanted to do now is just pause for a minute and do a very quick poll. And I wanted to ask you what approach your ICS is taking to meet the needs of children and young people. And hopefully you'll be able to see the poll in front of you in a minute. And you'll have 4 options for questions within the poll. And we'll give you about sort of 30 to 40 seconds to respond. And we know that for some of you, lots of these responses will be true, but if you can just pick one that you think most represents what's happening in your ICS at the moment. See the results as they are developing, and the responses are really interesting. So I'm just going to give you a few more moments, and then I'm going to end the poll. And John, if we can publish the results, please. So what I'm seeing in front of me here is that the majority of you have got siloed projects and programmes across your organisations, and about 21% of you have actually got a strategy for children and young people that incorporates the voice of children and young people. And when we look at budgets and we look at whether you in your integrated care system have aligned budgets or pooled budgets for children and young people, the percentage has just gone up, but it was actually 4% before, it's now 6%. So that is just really telling in terms of the amount of work that we have to do on the ground at the moment. So if you are one of those ICSs that hasn't got a strategy at the moment, where could you start? And I think it's really important that you start with a vision from the perspective of children and young people, so that you really think about, what needs to look different from the perspective of the child and the young person in 3 years, in 5 years. What are the changes that we need to make? I think developing a clear set of principles around engaging children and young people at all of the levels, in terms of neighbourhoods, places, and at the system level, is really important. We know that it's at the neighbourhood level that most children and young people have the trusted relationships with professionals, with services. And the other element I think that's quite important going forward is really giving equal weighting to both health creation and prevention, and the areas that really address inequality and health equality, which are around service integration and optimisation. And if you are one of the 21% of ICSs who did the poll that actually said that, you have a strategy, perhaps the next thing that you need to be thinking about is your priority shared outcomes across the system. So what could these look like? Well, I've identified a number of priority shared outcomes there in front of you. But if we just pick one of these and we look at school readiness, this was one that Michael Marmot mentioned earlier. To achieve school readiness at a population level for children, they would need a supportive home and social environment, adequate stimulation, parents and carers that are supported in their parenting role, developmental delays that have been identified early and acted on, ill health, whether that's acute or chronic, that's managed so that it doesn't impact on their childhood development, and engagement from early years and school settings from families. So this really demonstrates, I think, the interdependencies across agencies that we need to achieve this particular shared outcome. And one of the things we need to think about as well is, how do we measure this when things are going well and when things are not going so well? And if you are one of the individuals that's at the point, which was the majority of you, where perhaps your ICB, ICS hasn't even thought about a strategy for children and young people, there's possibly one thing that the board could go away and do, and that would be, when they're thinking about their funding decisions, when they're thinking about which services to cut, to invest in, to commission jointly, to redesign, how would they justify that decision if children and young people were in the room with them when they're making that decision? And that would be a really good compass for ICBs to think about going forward. And before I go to share an example with you of an integrated care service partnership with VCSE sector, I just wanted to mention a collaborative piece of work that we're doing with Sir Michael Marmot's team in the Institute of Health Equity, because one of the things in Barnardo's that we believe is really important, as well as delivering excellent services, stimulating systems change, is we're wanting to work with 3 ICSs to develop a children and young people's health equity framework. So if you are interested, we will give more information later. Please put your contact details in the chat and we will be in touch with you. So Jen, if you could move
Barnardo's is a leading children's charity in the UK. Over the last 12 months, we've reached over 382,000 children and young people in over 790 services. 160,000 of these children and young people were supported through one of 62 Barnardo's children's centres and family hubs. Finley. Offering Finley the best start in life means health and care services departments.
The right to is tough, with agencies rarely collaborating or communicating. There's no single view of the child's health journey. Families are forced to repeat their story multiple times, and routine checks and interventions that could prevent serious problems down the line are missed.
It can be so hard to keep on top of all the different appointments and checks that your children are meant to have, and at different times and places we've often found we've missed something that's really important without even realising.
Integrated care relies on partnerships between the family and us, even when we know they are the key to efficient working and better outcomes.
Things need to change because families like mine that need the support the most aren't getting it.
Bernardo's integrated health model removes traditional silos and brings together on-the-ground expertise that means the service can now meet demand for comprehensive, child-centred health and care. Together, we've improved outcomes, saved time and money, removed duplication and avoided mistakes. We understand the infrastructure, networks and leadership required to connect sexual health advice. This is a value we add to the integrated health and social care that no one else can bring. At Birmingham Forward Steps, our NHS colleagues work hand in hand with the experts from Bernardo's to support and empower the families we see. We share our information across healthcare, education, housing and more to make resources go further. We can now really address health inequalities by taking actions on all areas of life that we know affects health outcomes.
Across Birmingham, we've integrated
to get to the root of the problem. Bernardo's Children's Services staff were trained to complete the 2-year checks, and now the service sees almost all of them. By doing so, Bernardo's were able to reach more families by going to where they are. We can be flexible and adapt the process to their needs. This has increased the uptake of the health checks from 50% to 84% in just 12 months.
We've had such a positive experience because of how close all the different teams are. They know about Finley's health record and we can get all of the guidance we need at the same time in the same place, which is fantastic.
Working together with our strategic aim to live healthier lives for longer. To be part of our success story, get in contact today.
Brilliant, thank you. Richard, I think that was the end of your section, wasn't it, as well? So thank you very much for that. I'm going to move us on very quickly because we're running slightly behind time. But I don't want Mo, who's coming next, to feel that she needs to rush her section when we've got time elsewhere. So we're moving on now to Dr. Mo Akindele, who's the consultant in ambulatory paediatrics at King's College Hospital in South London. And also on the senior leadership team at the Royal College of Paediatrics and Child Health. So, Mo, you're very welcome and very interested to hear what you have to say to add into the information this afternoon. Thank you.
Thank you so much. Good afternoon, everybody, and I hope that everyone is enjoying this as much as I am. It's a real pleasure for me to be here this afternoon, and I'm looking forward to sharing with you one of the most exciting projects that I've been involved in my professional career, which was a collaboration with the team at Bernardo's. And that was really looking at control literacy and reduce winter pressures. So ensuring that we're still on the same page, we know exactly what we're talking about. I think our language is evolving at a pace. To start off without anyone knowing exactly what we're speaking of. There are many different definitions of cultural competency, and so just to begin one of the most accepted definitions, the culturally competent communication refers to communicating with awareness and knowledge of healthcare disparities and understanding that social cultural factors have important effects on health beliefs and behaviours, as well as having the skills to manage these factors appropriately. And we've been hearing throughout this afternoon's presentation how important it is. So I'm going to start with an overview of the campaign and just describing exactly what we did and providing some of the impact and outcome factors and with some reflections of involvement and how it may be relevant to all of us. So this relates to a project that we did related to the RSV surge which occurred in the winter last year. Anybody babies and children, you'll know that RSV is a regular occurrence in winter. When we had the intersection of the pandemic along with the RSV surge, what happened was that there was a disproportionately large increase in babies being impacted by RSV for last winter. We in the UK had the privilege of advance warning from our Australian colleagues who experienced it 6 months in advance of us, and that enabled us to start thinking of preparing. And so this was primarily affecting children, young babies really, those under 3 years. And we already know about disproportionate impact on certain communities with Black, Asian, minority ethnic, and that again was predicted with this RSV surge, particularly those living in poverty. Now, for me as a hospital paediatrician, I'm well aware that the vast majority of babies with RSV are not the ones that I end up caring for. It very much is the tip of the iceberg that we see, and the vast majority of babies can be adequately cared for with self-management strategies in their home environment and needing some support from primary care. And also, the surge for last winter was happening at a time when we knew that capacity within the NHS was stretched beyond belief, both from a physical capacity perspective, but also staff who'd been working through first, second and third waves of COVID. And I'm sure it will resonate with many in the audience that feeling of individual and collective burnouts, which is really widespread. So the foundational principle of this approach really was being collaborative in partnership. And the 3 key elements were the expert advisory group that I had the privilege to be involved in, clinicians across the spectrum from primary, secondary and tertiary care, bringing a wealth of expertise. Having grassroots community organisations involved, and there were over 100 grassroots community organisations involved, was absolutely crucial, and they were critical in co-producing how this programme rolled out. And Bernardo's were the linchpin. We've already heard incredible things about Bernardo's. I learned a lot more about Bernardo's in the process of working collaboratively with them throughout this project. So some headlines about exactly what we did. The funding came through Health and Wellbeing Fund, and that was applied for in advance, and the partnership, as I've described, was absolutely essential. The to families was a telephone helpline, a web service and a website, and these contained healthcare information which were through the helpline with trained advisors and therapists. So the Bono helpline, and Bono means in Urdu and Hindi to speak or to talk. The advisors were trained specifically, upskilled to deal with the families and children who would be getting in touch for advice for respiratory support for their children if they were having symptoms of being unwell. From the outset, it was also intended that we would be addressing wider inequalities. With sites on that was absolutely embedded in how the programme was co-produced, how the helpline advisors were trained, the range of languages that were available, and the streams of dissemination that we used. And the co-production is essential. You can't underestimate authentic co-production and how essential it is to get things absolutely right. And once the programme was up and running, we really reached out quite deeply to using quite a widespread marketing strategy. And again, having Bernardo's as the linchpin within this, with the 630 high street stores as well as the hubs, were absolutely essential in getting the message out there so that the families and children that needed to use this service were aware of it. So some of the resources that were created and used to disseminate about the programme are highlighted here, and they included being available in a range of different languages. We, where possible, didn't reinvent the wheel. The traffic light system for estimating what to do when a child is sick is already in widespread use. The Royal College of Paediatrics and Child Health has used that, and that was used widely at the onset of the pandemic. So it wasn't necessary to reinvent the wheel, it was just making it a lot more accessible. And so by translating into different languages and using more widespread means to facilitate the spread and adoption, and there was simple use of QR codes that their families could use in order to access the website. Within the NHS, the reach was also very wide throughout acute trusts. So 231 NHS trusts were used to disseminate the information. And the VCSE were absolutely partners, again, in disseminating the information. And 42 LCS partner networks were involved in spreading the word about the Bolo Helpline. We partnered with the NHS Race and Health Observatory as well, using their following to be able to reach 7,000 more people. And digital posters, such as those highlighted in this slide, were used within 16 NHS trusts to help spread the message even further. The work of Paediatrics and Child Health, as I mentioned, was involved in promoting this, as well as the Institute of Health Visiting, where a webinar was convened. The grassroots organisations were absolutely instrumental, and over 100 of them were involved in spreading the message, as well as, I mentioned, Bernardo's extensive retail shops and family hubs as well. So in terms of reach, we have set targets for the website of 10,000 and far exceeded that with over 18,000 hits on the website with the page views, and 3,000 of those clicked through to the multiple resources which were available on the website. And so that was a great overwhelming success, using the digital format to make things accessible for families. And in terms of individual families who were supported through their helpline and focus groups, there were 716 of those that were reached. And this the number of page views over time on the website, we could see quite clearly the peaks that aligned with webinars and times when we were actively reaching out. So there were several key themes that came from the qualitative data which was collected from the families who were using the helpline. And the key themes, just demonstrated that where you design a service in a bespoke manner to reach a certain community, and you target them, that when they're reached, they really feel included. And when we use generic methods of spreading and adopting healthcare messages, there are people who get left behind, there are communities that get left behind. One point I wanted to highlight on this slide is back to about one of the NHS videos talking about skin turning blue, and a parent in here has commented, and that's something that we use commonly. That's how I was trained as a paediatrician. Those are the words we used. It's embedded in the app gospel that we use for babies. But we're only now really starting to talk about being more inclusive with the language in a culturally competent way, thinking about what does that look like on black skin. And it's really enriching for me to see that there's a wealth of resources that are now being designed to show what rashes look like in a range of skin colours, and that will facilitate early identification of conditions and earlier diagnosis as well. So the impact was phenomenal. There were 46% of those users who were given advice to support management in the homes. That was advice to support respiratory management of RSV for their babies in the home. There were 35 of those who were advised to contact their GP or their health visitor. An additional 16% who were given reassurance after they had contact with healthcare service. And over the course of the time of the helpline, there was only one caller who was advised to call 999 as an emergency, and on following up with that one caller, that call was entirely appropriate. What was really interesting is that over 50% of the callers to the helpline received wider support, and that wider support aligns with all of these wider social determinants that we're speaking about here this afternoon, which included support with registering for a GP, support with housing, support with debt counselling. And whilst I'm a big fan of digital and technology, and it's been incredible to do things in far different ways, I think agree that digital literacy, we've seen how that has really impacted those who are more vulnerable and those who are more deprived. And some of the calls we were able to facilitate the families to get access to the technology which they need, in that they're not digitally excluded. I wanted to share some personal reflections of my involvement with this project because I can't underestimate how much it has transformed clinical practice. And it's really just broadened the realms of possibilities. It's really changed my mindset in profound ways. It was invaluable throughout the time the helpline was functioning, that there was a pragmatic resource that I was able to place in the hands of families, and be it posters that were up in my place of work, or we had small credit cards, size cards to hand out to individual families. That's something that I used throughout the winter to hand to families that I was encountering in an outpatient setting, and those who were being discharged from an inpatient setting as well. It also really broadened our concept of solutions to the NHS workforce challenge that we're facing. There can be a tendency for healthcare professionals to feel that we are the only ones to do this, but actually there's a lot of work that we can share with others within the voluntary sector and others who are actually better equipped than us to deal with these issues. And working collaboratively in that way, we can all actually be effective with our time and a lot more impactful in what we're trying to attain. An example, I'll be in clinic tomorrow afternoon, and increasingly with the cost of living crisis, finances and talking about money is becoming an integral part of my consultations, irrespective of what care issue the child has been referred for. Continually writing letters in support of housing, and I don't even know if there's an evidence base. I don't know if my letters are impactful, and yet by working in creative ways with organisations such as Bernardo's, projects like the family partnership that has been run through the emergency departments, pairing families up with help with professionals who can actually help them in an impactful, evidence-based way, freeing up more of my time to focus on the medical aspects of the consultation. It really has to be a more collaborative way of working and looking forwards. Personal reflections has also included me thinking in a very different way about how and what future collaborations are possible. And again, to the and the cost of living crisis, there's another project that I'm embarking on that I can say really has been shaped and informed by my collaboration with Bernardo's. In terms of lessons for the NHS is one of the largest and most diverse employer in the nation. But I do feel that we have yet to really harness the true benefits of this diverse workforce. And there's good news and the bad news. The bad news is that we're part of the problem. The good news is that we can equally be part of the really impactful solution. Winter is an annual seasonal event, and yet we talk about winter crisis as if it's coming as an unexpected event, and certainly looking at a more perennial way of dealing with these surge and waves in activity that we see and the change in the disease profile has to be a way for the NHS to look at this in a more sustainable manner. And valuable lessons learned. Obviously, this project was it's focusing on some of our most important citizens, the children and babies. But it was interesting in talking about this project that colleagues of me working in adult renal transplantation and colleagues working in the sickle cell service were really interested in the approach that we used and looking at how they would adopt that for their services, which offer and reach a completely wide, a different range of our citizens. And we had the chance to speak at the NHS Confederation about the Bio project recently, and again we had people with cancer services and a real wide variety of ranges coming up interested to look at how they can do this in the service as well. So we did have an opportunity for questions.
Brilliant, thank you, Mo, for that, and clearly massive change in practice and change in the way that you work as well as a result of this project. So thank you for sharing that with us. We're going to move us on swiftly to the last session of the afternoon, which is the My Time Cumbria case study. I think this is a video that's going to come through. It's about 5 to 19-year-olds with anxiety, low mood and depression, and some innovative innovations for that group of children.
So we're going to play the video now. Hopefully there will be no interruption. Sorry about earlier on, it was due to a YouTube streaming issue. We will be replacing the video for the replay. Enjoy this video. Thank you.
Hi, my name's Nicola Byrne. I'm a Children's Service Manager with Barnardo's, and I'm here today to talk to you about the My Time service in Cumbria.
Hi, good afternoon. My name is John Daly. I'm the Strategic Programme Lead for Mental Health at Barnardo's, and I'm here to talk to you about the ACT service.
I'm going to take you through a presentation now about My Time. So, the My Time service has seen a real increase in need in Cumbria for children and young people who need support with their mental health and emotional well-being. We've seen a steady increase in referrals year on year, and as a consequence of that, waiting times have grown quite significantly. Not only are referrals increasing, but also the complexity of some of the cases that we see within Cumbria. So, probably really noticeably, the number of children experiencing problems with disordered eating, and also with a diagnosis of ADHD or awaiting a diagnosis of ADHD. Our system is straining, the whole sector system is straining, and there's a demand for more support, and that's a real challenge. In 2016, we work with children and young people who are experiencing mild to moderate mental health presentations, so anxiety, low mood, depression. We work with 5 to 18-year-olds up to 25 years of age if having information around ADHD, eating disorders, and we're going to do that, and we hope to do that in conjunction with our CAMS colleagues, so we can bring in some specialists. My Time's a commission service, and we operate across the whole of Cumbria, and we mirror CAMS delivery, so we've got a north, a south and a west service, and we're a key part of the mental health provision for children and young people. So in the Thrive model, we're the getting help stage of support. We're commissioned across the health and local authority, and we've really got a positive relationship with our commissioners. They work very closely with us to ensure we've got the best mix of support that we can. Also with partners, partner agencies. The service has been very lucky, and we've benefited from some great contracts and with significant delivery times, so that we can build our core service and extend into reducing our waiting list. So why does My Time work? I think ultimately it's because we're led by children. We listen to what children want to work on, how they want to work, and that's what we try to do. It's always good to know what schools, parents, doctors think, but ultimately it's the child that decides. And that fits into a framework that we operate by, our CSO framework. It's a delivery model that ensures a consistent quality across all of the services delivering mental health work, and it incorporates the voice of the child, the systems around the child. It makes sure that we're solution focused, and also that we work in an evidence-based way. What we do is, as I said, is we really hope to support communities, children, young people and communities, to be able to support themselves. We know that services don't fix people, people fix people. So we want to give them the tools that they will need to do that and to respond to need. We've got a great staff team, which is essential in a sort of an area like Cumbria. We're obviously one of the third largest. We are the third largest county, really sparsely populated. So the fact that we moved very quickly in the pandemic to digital delivery has really helped. Now, even though we've got a hybrid model, we're still able to cover some really wide areas very effectively. So that's been great. How do we know that our service works? We look at outcomes with children. So we'll look at where they are at the beginning of their journey with us, and then also at the end. And what we see is that they consistently move from a state of clinical distress to a point of well-being at the end of our support. And that's their scoring, their feedback, their words. It's very reassuring. And the numbers are great, the graphs are great, but these are the words of the children that we work with, the parents who live with those children, and also our commissioners. And I think we can see that there's a real tangible change for children. So talking about a child that can move from being so socially anxious or so anxious about the community that they don't want to leave the house to be able to get on a train with friends, go out and socialise. It's absolutely extraordinary, and the difference that will make for that young person and their family, it's phenomenal. A young person that couldn't speak about how they felt or hadn't been able to find the right person or the right way to do that, and came to us and we were able to provide that platform for them is just it's the reason that we're all here, so that's good. Our commissioners are, they're fantastic. We've been able to develop really good relationships with them, and they allow us the space and the opportunity to do this work, which gives us the space, I suppose, to do what we do best. Thank you.
Brilliant. Thank you very much, Nicola. So now I will talk to you about the app service that we have developed in Barnardo's. So this is the Mental Health Additional Capacity Team app, a really exciting development which I'm delighted to share with you today. So we know about the challenge that we're facing. We know that children and young people are waiting for ever longer periods of time on CAMHS waiting lists. Very often during that period their needs are getting worse, and we know that for many children who have mild to moderate mental health needs, they can often end up waiting long periods of time for support and then not meeting at the end of all of that. We also know that children and young people consistently tell us what they want is choice in terms of how they access services, where they access them and when. We know, and we've learned from a lot of the services that we have delivered organisationally, digitally, that digital support can work really effectively and can be much more accessible for many children and young people. We also know that funding sometimes comes up around addressing waiting list pressures, but very often it's short-term in nature and it's available at very short notice. And that presents real challenge. The way it works is we have referrals that are made into the app service. The case will be allocated, an initial assessment completed, and then the child or young person will receive a virtual offer of either one-to-one sessions with a real wide range of therapies available, delivered through our Barnardo's Journey app, or they will receive group therapy delivered through 6 sessions of different types of support. Routine outcome measures are completed during each session. At the end of the intervention, a review is completed for the young person and a case closure summary is produced. In addition, we will be providing summary reports of the overall activity and impact of the service to the organisations that commission us. So in terms of how it will work and why the service will work. So how the service will work is the app team will be commissioned on a unit cost basis to deliver a set amount of virtual one-to-one group interventions over an agreed period of time in different localities across the UK. We're delivering that support simultaneously in different places. In terms of why it will work, we as Barnardo's have got a really strong track record of providing effective support to children and young people with mild to moderate mental health needs, in person and also virtually. The service will be able to start working in the locality very quickly to ease that waiting list pressure, and it will be able to deliver timely support to children and young people who would otherwise be waiting for longer periods of time for that support. It will be flexible and responsive, and it will be led by a team of qualified therapists who are able to deliver a really wide range of interventions, crucially at the same quality as if they were delivering a locality-based Barnardo's service. The service staff will be trained in the CISO framework and will work to that, which ensures consistency and standardisation of practice in terms of the therapy they're delivering. And it will be delivered through the Journey app, which we have developed within Barnardo's with extensive input from children and young people to make sure that it works most effectively and really helps us to deliver this type of support to children and young people. So we're looking for more areas to pilot and expand this work, and if you're interested and would like to find out more, please don't hesitate to get in touch. We're absolutely delighted to hear from you. So thank you very much.
Thank you. Sorry, John. Thank you to John Daly and Nicola Byrne The details for both of you are going to be live on the webinar for people to get in contact. I'm going to also add both presentations into the file tray for download. Is that okay with you both?
Yeah, that's great.
Great. Thank you very much.
Hello, thank you for that final presentation, and the chat has been really active during the last set of presentations, so I'd encourage people to go through the chat if you haven't already, because there's a lot of people that are pointing towards resources.
Dreadfully sorry, Elliot, I can't hear you, and I don't know why. So, Roxana, please may you speak.
Is that any better?
Yes, I'm speaking, and I can hear Elliot absolutely fine.
So, okay, I shall carry on speaking, and hopefully people will put in the chat if they can still hear me. If Roxana can, hopefully then others can as well. So I encourage people to look at the chat because there are several links being put through to resource websites, but also asking for examples as well to be uploaded onto those. So Michael's had to leave us, I'm afraid. There are a couple of questions, I think, in the last 5 minutes before we close that I wanted to raise. One was about the co-design with children and with diverse groups. So I guess the co-design with children, Roxana, was sort of aimed towards you in terms of how do you involve children in the design of those groups, because I think that's been a theme coming through a couple of the Bernado's presentations. But also, Mo, from your point of view, how did you engage wider groups and groups and diverse communities in the design of the services that you talked about? Perhaps Roxana first, and then Mo.
Thanks, Elliot. One of the really interesting pieces of work that we're doing at the moment with Friendly ICS and their board is actually looking and working with them to really understand right from the beginning how can the voice of children and young people be represented at board level. And so they have developed a concept of a shadow board, and that particular board will then link to a place-based level, and they very much want that board to co-create those solutions at a place-based level. So it's just really, to some of our services, we have really bright, vivid colours that have been chosen by children, names that have been chosen by children, and the approaches have been very much developed by them as well.
Thank you. Mo, do you want to come in?
Yeah, certainly. So it's really to complement what Roxana's saying, in that I think we can underestimate the impact, the strength, the opinions of children and young people's voice. And I have a second hat that I wear, College of Pediatrics and Child Health, and I lead with the engagement committee there. And the work that's going on with young people engagement there has become so embedded in absolutely everything we do, to the extent that there's a young person on the interview panel when the chief executive of the college was appointed at our annual conference that we had in the last couple of weeks. Children and young people are the opening memory, they're closing, and they're embedded throughout. And for those who are specifically interested in terms of examples and ways of means, there are resources available through the RCPCH website and the engagement committees and us and on the website, and we can share the link with the resources that go out. There's a lot of really pragmatic and authentic ways of engagement, and there's also a book that's been published. So I think sometimes people can find it hard to access the resources and to get good service examples of how it's done, but there are a lot of resources out there which we're happy to share.
And I think that the other question, then I think that's because it's come up as a theme in the questions, is how do people get started on that, and how do people get started on this? Do they? What would your bits of advice be from both of you in terms of looking at some of the case studies that we've had this afternoon? Find out everything first. seek out all the information or throw yourselves in there? Which one would you go for in terms of really starting on these things and starting on these projects? What advice would you have for people who are listening? Mo and then Roxana.
Yeah. I think it's finding like-minded people and gathering together and moving along in that way. For me, it really has been, by means of getting engaged in this work, that opportunities like the collaboration with Bernardo's has come to fruition. And, even though the project we initially worked on, creative and thoughtful of going to where people are, not to sit within your four walls, whether that's in an acute trust or a community setting, but actually be creative about going out to religious organisations or different settings. Go out of your comfort zone geographically and literally, to where people are at to get projects up and running. That's what I would say.
From my perspective, Elliot, I think that it's really for me about being prepared to take risks, to actually do things differently and not see the traditional challenges that we see in front of us around budgets, around categories, around this is the way that we've always done things around here as barriers. And within the process of, completely agree with Mo in terms of getting that constituency of support of like-minded people. It is important too to include the gatekeepers, the people that are actually sometimes the blockers within systems, and think about how you can actually win those round as well as part of the solution in order for that solution to become sustainable. I'd be really interested in knowing your thoughts as well, Elliot, as a CEO and as a member of an ICB too.
Yeah, on that particular point, I would say throw yourself in actually to some of the service design, and as I was going to conclude, work with others to do it and work with communities on it, because actually sometimes the NHS it tries to find every perfect bit of information in order to make a service change, and sometimes we just need to throw ourselves into it and then work out the finer details later as to how we do it. I'm gonna that would be my advice, and do that with enthusiasm. I'm just going to conclude us. It's been a brilliant session. Thank you, Roxana and team, for organising, and everybody at Bernardo's for organising and bringing us together this afternoon. We've heard, we've seen in the chat that people are massively inspired by the speakers that we've had on this afternoon, and I think that's been brilliant in terms of the expertise that we've had within the virtual room. I'll bring out three themes out of this afternoon, but you might well have themes of your own as well, because there's been such a rich information locally to do something different. The second area that I think really came out through a lot of the questions and through a lot of the sessions was about the integrated care, so the fragmentation of services that we currently have, and how we get a system that is much more focused around children, young people and families, rather than around the silos that we've designed for them as health and social care and voluntary sector organisations. So how do you get children and young people to tell their story once, principally, rather than many different times, and how can you get then wraparound services behind that story that means it's much more integrated from a children, young people and families perspective. And the third was really I was going to say about hence my question to you, Roxana and Mo, that you threw back on me, which is about be bold and ambitious about service change. Don't be restricted by the models that are currently there and the existing models. Think different, think bigger, think more integrated in terms of how we deal with children and young people, and how we respond to the challenge that Sir Michael outlined right at the beginning of that. And find like-minded people. There is a tremendous energy that comes from finding like-minded people, infusing them, and getting together as a group to make real changes. Those are the three things that come out of it for you, but I hope you've enjoyed this afternoon. Thank you very much for joining. There will be, as I said right at the beginning, an evaluation that comes out as a result of this, for your thoughts about how we can improve these sessions in the future. But thank you all very much for joining us.
I'd like to thank you all for today. Thank everybody for joining us. Apologies, there was a couple of glitches in the streaming service via YouTube. What we're going to do is actually replace those videos so that there won't be any glitches in the replay. The chat log will be sent to all speakers. If there's any questions that haven't been addressed, then we will address those too.